Hello, everyone, and welcome to Coloplast's Platinum-sponsored session. My name is Cassie Oliverson, and I am the Coloplast Wound and Skincare Marketing Manager for Canada. I also want to introduce you now to Dr. David Keast, who will be presenting the Global Consensus Towards Fewer Days with Wounds. Dr. Keast is a world-renowned physician. His contributions to the wound care industry are admirable, to say the least. If you would like to learn more about Dr. Keast, please refer to the Wounds Canada conference app for a complete bio. During the presentation, please input any questions you have for Dr. Keast into the Zoom Q&A box. I will organize the questions and pose as many of them as I can to Dr. Keast at the end of the session.
Welcome to the Global Consensus Towards Fewer Days with Wounds. I'm pleased to present this on behalf of Coloplast today. I do have to make a disclaimer. I am receiving a paid honorarium for delivering this presentation today, and I'm also a paid consultant for the Coloplast Corporate Global Advisory Board. We've set a number of objectives for today's session. By the conclusion of this presentation, the participants should be able to describe what we mean by the background to this consensus project, define the term GAP and state its importance to wound healing, review the consensus process that we used, and state the conclusions of that process. So why did Coloplast Skin and Wound Care initiate this consensus project? Well, if we really look at this on some global data, we can see that chronic wounds globally affect probably more than 50 million people. And many patients have their lives completely altered by their ability to live and work and play based on their wounds. And we also know that in particular with diabetic foot ulcers, if not properly cared for, up to 28% of them can result in an amputation. If we look at a recent survey of clinicians about wound care and looking for more education, we find that healthcare professionals often are receiving very limited training. We also find that established guidelines in many circumstances are lacking or not easily available to clinicians. And a lot of this comes from learning by doing. I don't remember whether you've found out, but when I was in medical school, I was taught, see one, do one, teach one. So what were the steps in the process that we used here? So the first step of all of this was a literature review. And so this allowed us then to meet with the expert panel and to develop survey number 1. And that survey was then sent out. The results of that survey were collected. They were consolidated together. There was meeting with the expert panel, and the second survey was developed. This survey then was sent out again to the participants in this particular process. The results came back from that, and the collected insights in the survey were consolidated again and analyzed. And this allowed then the group to develop themes and questions that would guide the Delphi process. This then led to the Wound Care Days workshop. The results of the Wound Care Days workshop with an extensive amount of work were collated, put together, transcribed, analyzed, and eventually, after the consensus panel was finished with these were published. And the first 2 of these papers should be available at this point. So what exactly is consensus? Consensus building is a process of helping groups to reach a common understanding on an issue or a solution. It is a process of helping people to think together using the critical thinking skills that they have to make decisions. It helps them to build a collective understanding and an intelligence of the issue. The group really comes together so that we have a concept of consensus that is building on all of our wisdom. In other words, the wisdom of the whole is greater than the sum of the parts. So if you're going to do this particular process, you have to determine this through a valid approach. And the modified Delphi process is one of those approaches. It's a structured method for collecting information. It develops as a forecasting type method. It relies on expert opinion, allows for geographical spread, and allows dialogue. So if we look here at the cycle at the bottom, you can see that we may have analyzed a current situation, which leads us to develop a series of questions. These are then put out to the group. They're discussed back and forth. Consensus is reached, and then you go back through the process again. And we were very fortunate to work with the Bain Group, which is an expert group on working on panels for consensus building through a modified Delphi process. So in November 2019, Coloplast gathered the experts together in Denmark. There were 85 experts from around the world. They came from 19 different countries. We worked through consensus on how to manage the gap, to determine the product that should be provided under those circumstances. And we looked at improving the outcomes for patients. So as I previously mentioned, and you can see in the diagram here, that our wound care experts came from 19 different countries, and we collaborated over a 4-month period. So that collaboration extended to online in the 2 sets of surveys, back again in person in the wound care days, and then following the wound care days as this is worked up. So we had the combination of online dialogue and face-to-face meeting. So if we look at the particular group, one of the key things that turns out is that 69% of the participants had specialized wound care credentials. So if we look at the diagram over here on the circle with the hole in the center, we can see that if we look at the type of education, we have certified people here in the blue. We have people who have completed specialized education. We have special devised training. So you can see that the bulk of these people have received very specialized wound care. We also noticed that 61% were nurses and 29% were physicians. And the nurses break down over here on this side among registered nurses, nurse practitioners, and nurse specialists. 29% were physicians. 86% of the participants had more than 10 years of experience. That's quite an astounding number. At least half of these participants had more than 20 years, and 86% had more than 10 years. And again, you can see that in the pie graph in this particular slide. So if you're going to have this kind of a survey type method using online surveys, you have to set a barrier at which you will assume that you have particular validity to what you're doing. So data validity covers the data quality as well as the consistency in that particular data. And where we set the barrier was at 40% response rate. So if you look here to survey 1, you can see that we had over 80% response to the first survey and over 70% response rate to the second survey. So this really tells us that the data collected through these surveys have high validity. So what does managing the gap have to do with the consensus project then? So the aim of the consensus project was how to manage the gap. And you can see here a picture of one of the groups on our day on the road to consensus. The focus of the consensus project was on managing the gap between the wound and the dressing. So the literature identifies that this is a significant problem, but there are very few guidelines on how to go about it. So what do we mean by the gap? It really is that dead space that exists between the wound and the dressing. And it's imperative to manage this dead space if we're going to improve outcomes in healing. And this has been recognized for a significant period of time. For me personally, this occurred in the year 2000. In that particular year, a group of Canadian clinicians published a document, one of the first, on wound bed preparation. And in that document, we identified managing dead space as a key component of managing the wound bed preparation. Here you see on this particular slide a summary of a number of papers that have identified the importance of managing the gap and how this is important in managing bacterial loads and the effective management of the peri-wound skin as well. So what was the consensus workshop like when we were there? Well, what we had put together from the first two surveys was a series of 8 areas for reaching consensus. And those 8 areas were wound assessment, wound bed preparation, managing the gap, effective exudate management, recognizing the early signs of infection, managing biofilms, holistic wound management, and patient education. So at each of the stations in the auditorium where we worked, you would see that there was a large board set up. The questions on one of these topics were at the top. There was an area for a group of approximately 8 or so clinicians to meet together to discuss these, to come up with ideas on how to deal with that particular issue, to write them down on blue Post-it notes and put them up on the board. So what were the key findings from this consensus workshop? So the participants really agreed on wound assessment when they were looking at the gap on some of the key things that were important in wound assessment. So we really needed to assess the depth, undermining, tunneling, fistulas, and underlying wound bed structures, and the topography of the tissue in the wound bed, how much granulation tissue was present and how much other types of tissue, such as necrotic tissue. It was important to look at exudate, both quality and quantity, and these included things such as color and odor. Age of the wound was very important, as many of the participants recognized that there is extensive literature published on the older age of the wound and its effect on wound healing outcomes. Infection and biofilms were also one of the key things that we need to look at, and colonization in the wound. We needed to look at the wound edges and the peri-wound skin and its characteristics. And we needed to understand why the wound was there, what was its etiology. And these were all key portions of assessing the wound, was part of assessing the gap. So why was the managing the gap so important? Well, managing the gap was important by agreement of the participants in providing a moist wound healing environment, in decreasing the risk of biofilm development, in keeping exudate from leaking onto the peri-wound skin and damaging it, from decreased risk of infection, and by removing pooling of exudate from the wound. All of these were important things that need to be managed through appropriate management of the gap. How do we know that we're being successful? What are the success factors that we should look at? The group agreed on the following. Effective exudate management was one of those successful outcome measures. Wound healing progress is the wound making progress. Management of the wound bioburden. How do you assess for this? How do you make sure that you are managing it appropriately? Decreased or absence of undermining. If you have no undermining, the wound is more likely to progress to healing. Decreased signs or absence of maceration of the surrounding skin. There's growing understanding that the barrier function of skin is greatly important to wound healing, and managing the appropriate barrier function of intact skin is one of the key things that we need to do. So what are the things that we need to have from a dressing perspective in order to manage the gap? What are the important features? Well, the participants really agreed, most importantly, that wounds extending down to 2 centimeters in depth was the conformability of the dressing. So what properties should the dressing itself have? Well, the group agreed that they should have antimicrobial properties where necessary, conformability to the wound bed. There should be vertical absorption of exudate and protection of the surrounding skin by doing so. Patients should be comfortable with the dressing and they should be able to actually apply it. Dressing isn't particularly good if the patients aren't able to get the package open or to apply it easily. And it needs to promote a moist healing environment. And most importantly, it needs to be cost effective in today's healthcare world. So what were the results? So the consensus was reached when more than 80% of the participants agreed, and where nobody disagreed. So in other words, 80% agreed, they either strongly agreed or agreed, and those that didn't agree at least agreed to support it and did not support a negative recommendation. And really what they should say, agreed that wound care treatment should be primarily focused on providing a healing environment. One of the most important factors in promoting that optimal healing environment was managing the gap between the wound bed and the dressing. Gap management is the ability to control exudate, and that is a key thing in approaching good wound healing. So consensus was reached through the collaboration of the wound care specialists on this particular group. As I pointed out before, 85 wound care specialists developed an international consensus on how to assess and treat chronic wounds to decrease the burden of wounds on both patients and the healing healthcare system. Consensus was reached on the importance of effectively managing the gap between the wound bed and the wound dressing. So this includes managing exudate, creating an optimal healing environment, and decreasing wound healing time. The results were published in a paper, which was published in Wounds International this past month. And wound assessment plays an absolutely critical role in what we're doing. So if we take a look at a particular statement that came out of the consensus project, assessing the wound at each dressing change provides an opportunity to diagnose and treat a wound infection in the early stages and decrease the potential of limb or life-threatening infections. And you can see that we had well over 100%, almost 100% agreement on that particular statement. So the conclusions from the consensus project really indicated that we really need to have evidence base, we need to have it based in experience, and we need to have accessibility guidance for the management of the gap between the wound bed and the wound dressing. And this is required to decrease the number of days for wound healing. This then leads to the idea that we should have a guidance document to help stop routine or ritualistic care and encourage people to think through holistic wound care and to focus on what is required. I'm constantly reminded of a colleague of mine who used to say, if you do what you've always done, you'll get what you always got. And so it really takes us back to this idea of critical thinking with support from guidance to help us to approach wounds in a holistic manner. And while the project reached consensus on the importance of managing the gap between the dressing, it really did not provide any guidance. And so this is what we're further planning to work on this. I'm pleased to tell you that this particular group, involving Christopher Hoffman from Coloplast and Kimberly and Mark from the Bain Group, won the 2020 Facilitation Impact Award for managing the gap consensus project that we undertook, and we're for achieving positive outcomes. This is a major achievement. So moving forward, there are some key pieces which will help you and your facilities to manage the gap. So as I pointed out, we're looking at a 4-series set of articles. The first one on managing the gap is already published. The exudate management document also should come out very shortly. Preventing and treating infection and biofilms is due to be released in December, and holistic wound care management is to be released in February 2021. All of these will be published as a series in Wounds International. So the development of the treatment guidelines is then the final piece of this particular puzzle. And we're imagining a very large consensus group, this time probably involving at least 200 clinicians, which involves at least 2,000 healing care clinicians worldwide in developing these consensus guidelines. I am very proud to have worked with such a group as you see pictured here, who were the Global Corporate Advisory Board, who worked with the consensus group of 85 international clinicians, and our support from Coloplast in developing this particular consensus document. So hopefully by the end of this, we have really described the background for what happened in the consensus project. We defined the term gap and stated its importance in wound healing. We've reviewed the consensus process and we've looked at the results of the process. And we strongly advise you to go to Wounds International, which is an open online journal, and read the article which discusses the consensus in much broader detail. And I would encourage you to visit Coloplast virtual booth for any further questions that you may have, but the seminar is now open for questions.
Thank you, Dr. Keast. Dr. Keast, we have a question here from Sue. And Sue asks, how do you stop the wound edge from rolling in?
Well, that's an excellent question. It's not something that the consensus panel actually discussed, because we weren't really discussing activities such as that. I think that some of this may come out in the guidelines work that is proceeding from now on. Personally, for me, if we have rolled edges, we generally get rid of them. And I get rid of them by appropriate debridement of the wound and by surgically removing any undermining, using appropriate analgesia to do it. But as soon as we get rid of those rolled edges, we do see a significant improvement in healing outcomes.
Perfect. The second part of her question is, how do you stop maceration around wound edge?
Well, stopping maceration really is all about appropriately selecting your dressings to make sure that they absorb and carry away any exudate. So that's one part of it, making sure that you have filled any dead space so that any fluid does not have a chance to pool but is wicked into the dressing or a secondary dressing. But the other point that I would want to make about stopping exudate is, why is it there? And it really should send you back to look at, why is the exudate going up? What are the possible reasons for their increased exudate? They can be as simple as something where someone with a leg ulcer doesn't put the leg up anytime during the day and sits the whole day with the leg down and sleeps in the lazy boy with the leg down. I mean, it's as simple as that. But one of the most common reasons we see for increasing exudate is unrecognized bacterial burden in the wounds. And it often leads us to look at whether we're adequately managing that. Having said all of that, I can also say that when we start looking at underlying causes, we're coming to recognize the significant role that chronic inflammation plays in chronic wounds. And you need to be looking for what other causes for chronic inflammation may be there, because they will also encourage increased exudate formation. So possibly the consensus document that comes out on guidelines may mention some activities on that, but basically you've got my personal opinion on these, not what was in the document that we published.
Great, thank you. And there's another question here from Virginia, and it says, I have an orthopedic surgeon that refuses to allow us to pack THR site that has 5 to 13 centimeters of undermining and 5 centimeters deep. Is there a contraindication for prosthetic wound packing?
I'm sorry, what kind of wound packing? I'm not sure.
She's prosthetic wound packing.
So this is packing around a prosthesis that's been implanted and the incision's dehisced. I'm not sure.
Okay, that's what it sounds like.
Yeah, the only thing I would have to say about, you have to be very careful about packing. The word packing is not a word that I use. And the reason is, if you use the word pack, people take it as a challenge. And I have had notes come back to me. One said, I managed to pack 6 feet of vag packing into the wound. And that's not what we want to do. We want to lightly wick moisture out into a secondary dressing or into the primary dressing. So I would say we use things such as fluff, don't stuff, or wick the dressing away. But the key point, if you're going to do something like this, you have to be able to get whatever you put in there out. So it really is, one has to be very careful about applying packing to areas that you cannot see and applying packing material that cannot be easily removed. And you can assure that you have removed all of the packing material, because then it becomes a foreign body if you haven't removed it. So it's a difficult issue. And again, it's not something that was addressed. The only thing that I can say is that if you're having difficulty in this, sometimes one has to take a very gentle approach. One has to provide information to people that says you may want to look at this, but not being directive. And often people may change their behaviors or their feelings about things once they've read some information. So that would be my comment on that.
Good. And I have another question here from Nancy, and she's saying she's asking, there are some that state one shouldn't apply packing into tunneling wounds when one cannot see or feel the bottom of the wound. What does the consensus say?
Well, this consensus panel did not address that issue. So I can tell you what the consensus would say. And I agree with you, there is a significant amount of controversy. And I think I've sort of addressed this anyways. If you're going to put something into a tunneling wound, it has to be done in such a ways as that whatever you put in there has integrity, can be removed completely, and you know exactly where it went. So it depends on individuals what your approach is. And I would say there is still a significant amount of controversy.
Good, okay. And then with this project, what was the most enlightening part for you?
That's a really good question. I think it was an incredibly fascinating process, quite frankly. And what you have to understand is that you had people from 19 different countries. And we were put together, not all from the same country. We were put together in groups to do this Road to Consensus trip around to the 8 stations. We had not only people from different countries, but we also had people from different professional backgrounds. We had some nurses from different backgrounds, doctors from different backgrounds, even adjunctive healthcare professionals such as therapists involved. So the discussion portion of that was fascinating. And somehow or other, even though there was a significant language barrier in some of the groups, we seemed to manage to get around that language barrier. And I guess what's the most enlightening about it is, with this such a disparate group of people coming together, that they came to such a level of agreement on so many topics. And I think that's what's enlightening for me.
Great. All right. Well, it looks like there are no more questions at this time. So I want to thank you, Dr. Keast, and I'll close off the session by also thanking a couple of Canadians that also represented were part of this Global Consensus Project, who is Melody Yachenko and Anik Bellevue. And last but not least, I want to thank you for attending this session. And if you have any other questions, please feel free to come by the Coloplast virtual booth or the chat room. And upon ending the session, you'll also see an evaluation link, and that will appear in the chat box. Please click on the link, or feel free to also copy and paste it into your browser and take some time to complete the session evaluation. So we appreciate your time, and thank you, and enjoy the rest of your virtual meeting.